we're not only addressing quality of healthcare services in hospitals, but we're also addressing the underlying things that may deter women from getting timely prenatal care and having a healthy pregnancy. So we're very excited about the future and potential of this initiative.
Looking at the framework that DC Health first created at the very first Maternal and Infant Health Summit, we really see systems change happening.
It's an opportunity for us to unify, think, and come together and be productive. I couldn't miss it.
And you realize that it's a team effort.
Oh, 100%.
So I really like that a lot of the classes and workshops that we've seen, it's about getting both parents in.
We're not only seeing great outcomes, but that families really feel like they are a part of the process. But also the ideas and innovation that have also been sparked, the relationships that have happened from people meeting at the summit, the breakout sessions that have been added that really amplify other work that's going on in places that may have never been discussed before. That keeps bringing people back each year to the summit.
This time last year, I came to the Mayor's Summit. That inspiration pushed me to become a maternal health advocate full-time. We to date have helped hundreds of families as a result of coming to this summit.
If the children are healthy and the mothers are very healthy throughout the pregnancy period, that transcends to a lifetime of positive outcomes for the entire community.
There are couples who might be in same-sex relationships or in LGBTQ relationships that want to have children, and we want to make sure that people feel reflected in that conversation.
Improved birth weights, lower preterm births, women engaged in the first trimester more often. We find ourselves discovering new ways to intelligently engage the patient early on.
All of those solutions are going to affect our children, and that's what's important to me.
Those are the things that get me excited about our opportunities here in DC, because we've got a lot of good things to build on.
When a mother does have a healthy baby and she's healthy and she can just see the fruits of her labor and bringing life into this world, it's probably the most joyful experience a person can actually have.
As a person who's delivered thousands of babies, you can't help but be an optimist, because every time a child is born, you know that this kid has all the capacity to do wonderful things.
At this time, ladies and gentlemen, please welcome Dr. Faith Gibson Hubbard, Director of the Mayor's Office of Community Affairs and Executive Director of Thrive by 5.
Good afternoon and welcome, everyone. Look at all of us in this room today, here together after so many months apart. And while we are masked, and I do ask that you keep your mask on, I am so excited to see each and every one of you here in this room today, both in the room, but also so many people who are also watching with us through the app or through Facebook Live or on television and streaming this right into their home. My name is Dr. Faith Gibson Hubbard, and it is my distinct honor to serve as both the Executive Director of Mayor Bowser's Thrive by 5 DC and the Director of the Mayor's Office of Community Affairs. In the District of Columbia, while we think about maternal and infant health every single day, this time of year is particularly special to me. I love the summit, and I love this annual convening that we have where we can build collective impact to take action on issues and create opportunities in the spaces that we know are impacting our city and families and babies. We can work on this together, and every day, we, with the birth of a new baby, have brand new opportunities to experience joy and to feel the reemergence of hope. That hope and what we know is possible fuels us in our work. It pushes us to find creative pathways to equitable outcomes for all district families, birthing persons, and our babies. And over the last 4 years, we have harnessed this hope in community together, right here in this room, with the conversations that we have, with the relationships and work that we do together, and also for the great things and change that we know come from this time here today. It's just a beautiful experience that I know so many of us have been able to be a part of. This year, we are convening to talk about our village and how our village can keep pushing us forward and we can witness progress together. I cannot wait to hear about the discussions that will come forth from today and the great work that we will continue to do together as community. I want to first take a moment to thank our partners who have made this year's summit possible: Sibley Memorial Hospital, Care First, Johnson & Johnson, United Healthcare, March of Dimes, MedStar Health, White Ribbon Alliance, the George Washington University Hospital, Children's National, and Aetna. I also want to give a special thanks to all of our agency partners and offices who have made today possible as well: DC Health, the DC Department of Healthcare Finance, the Department of Employment Services, the Mayor's Office of Community Affairs, Serve DC, also known as the Mayor's Office on Volunteerism and Partnerships, and also a huge shout out to my Thrive by 5 colleague, Tiffany Wilson, and her hard work. But I want to close in very deep gratitude and also to give honor where honor is due to our fearless and phenomenal leader, Mayor Muriel Bowser. Mayor, I thank you for your vision that has brought us here today. It is your vision that has shed light on a conversation that is in the shadows in so many other places. A conversation that allows people to be seen and for their stories to be heard in a way that sparks action and results. Thank you for your vision and courage in bringing us here. And thank you for giving us the opportunity to come together and to create a model for other cities and states to follow. Your leadership is what makes our home stand above so many others, and definitely ready to be the 51st state. I thank you for this amazing opportunity to lead, and I thank you for your support. And without further ado, I would like to introduce to you our mayor, Mayor Muriel Bowser.
Good afternoon, everyone. I am delighted to see you all here in person and watching by the thousands on various channels for this very important discussion. So welcome to the 4th Annual National Maternal Infant and Health Summit. And please give a round of applause to everyone in DC government, Faith Hubbard, Thrive by 5, and all of our agencies and partners in bringing us together. This is now our second summit where we are having a virtual experience, and this year an in-person experience as well. And even before going virtual was a part of our new normal, we have always had a virtual option for this summit because we know when we talk about issues faced by women and families and healthcare nationwide, it is important to be available and being available in many formats. I want to just reiterate a few of the messages that you're going to hear over the course of today and tomorrow. You're going to hear about the critical connection between supporting healthy families and raising healthy children. I've spent, for example, the last 3 weeks visiting DC public schools because our schools are back open, and we're very excited to welcome children to in-person learning full-time, 5 days a week for all children. And at every school I've seen happy students and happy families, kids excited to be reunited with their teachers and friends. And at every school, my charge and the charge of our community is clear. How do we give children, whether they're 3 years old or 13 years old or 17 years old, every opportunity to thrive in the greatest city in the world? And what everyone today here knows is that the work begins long before the first day of school, and the work continues after our young people have grown up and graduated. If it was just about having the best hospitals in the nation, and we do, our work would be done. If it was just about increasing high-quality care, our work would also be done. And if it was just about having the political will, our work would be done there too. But it's about all of those things and more. Dr. Nesbitt likes to remind us it is about addressing the underlying issues that determine our health, too. It's about taking on the systems that put Black and brown women at greater risk before, during, and after pregnancy. And now we face a new challenge. We know that the systems and structures that perpetuate inequalities and disparities in health outcomes have been exacerbated by the pandemic, and that women, particularly women of color, have been hit hardest, both personally and professionally. We know that, for example, that there are 1.8 million fewer women in America in the workforce than before COVID. One study found that 80% of moms with kids under the age of 12 were responsible for the majority of distance learning in their homes. Anybody know about that? That there's evidence to show that women are being disproportionately impacted by Zoom fatigue. And while we may not yet understand the full scope of these effects on women and their families, we can anticipate that the ripple effects will be far-reaching and long-lasting. At each of these summits, we have sounded the alarm on the fact that Black women are 4 times more likely than white women to die from a pregnancy-related cause. But if we're serious about closing the gap, that can't be the only alarm we sound. In our experience with COVID, we've learned, and it has taught us a lot of lessons. But one thing that we have learned is that the decisions we make around health care really affect the experience of Black women in our city. We know that, for example, that child care is health care. And across our nation, Black moms are less likely to work from home, less likely to be able to take time off from work, and more likely to be solely responsible for caring for their children. In fact, when we came together at this summit just 2 years ago, we focused on centering the narratives of moms and the connection between maternal and infant health and early learning. Since then, in DC, we have piloted and then made permanent a new child care tax credit to save families up to $1,000 per child every single year. It's a good thing. And in line with our city's longstanding commitment to free preschool, or free pre-K3 is what I like to say, we also opened 2 new standalone early learning centers in DC public schools. Last year at Stevens School and this year at the Military Road School. And also this year, in the budget that goes into effect in just 2 weeks, we invested $184 million to expand access to affordable quality childcare and strengthen our early learning system in the District of Columbia. And just like childcare is health care, so too is affordable housing, especially when Black women are the most likely to face eviction. And we know that a living wage is also health care, especially when Black and brown women are overrepresented in lower paying jobs and the most likely to benefit from the $15 minimum wage that we have here in Washington, D.C. Last year, we also touched on these issues when we strategized about using lessons learned in the pandemic to better inform our approaches to healthcare and make our systems more responsive to the needs of families. Since then, we've gotten more than $140 million in federal relief into the community to pay rent and utilities for our residents. It's a good time to remind everyone that Stay DC can help residents impacted by COVID to stay in your homes. So please contact us at stay.dc.gov. We've also quadrupled our investment in the Housing Production Trust Fund from $100 million to $400 million. We've expanded our use of telehealth to support critical programs and keep women connected to their doctors. And in the coming budget, we've allocated $8.5 million to support 5 centers of excellence at Howard University, including a center on women's health. And if you really want to see a big example of what we've been working on a number of years, bringing all parts of the government together to focus on making sure we had quality care in Ward 8 at St. Elizabeth's Hospital, on the St. Elizabeth campus, I should say. In 2015, we announced our plans to bring the entertainment and sports arena to the St. Elizabeth's East Campus. We said then that our commitment was bigger than basketball, and we certainly meant it. We've been, of course, putting together a plan to address disparities, economic, housing, jobs, and education. Today, the new arena is built. In fact, we've already won a championship. The WNBA championship banner flies there. But the campus is also welcoming new residents because new affordable townhomes are being sold there. We broke ground on a new Whitman Walker healthcare facility. A new shelter for men experiencing homelessness is being built and being built by the residents of that shelter. The campus is no longer just a vision of jobs and prosperity. It is the source of jobs and prosperity. And at the center of it all will be a brand new state-of-the-art hospital, and we're very proud of that achievement. Today, I come to you with more good news. Today, we are proud to announce that we have an agreement in place with the Children's National Hospital to operate and staff the Pediatric Emergency Department and the Neonatal Intensive Care Unit at our new hospital. So let's hear it for Children's. We know what that means for babies born all across our city and in Ward 8, and we know what Children's National means to our entire city. I want to thank everyone who came to the table to get this partnership in place, especially Kimberly Russo, the Vice President of Universal Health Services, who will operate the new hospital at St. Elizabeth's, and Dr. Kurt Newman, the President and CEO of Children's National. Please stand and be recognized. The new hospital at St. Elizabeth's is evidence of what is possible when we recognize a challenge and work together. So we're going to stick together on these tough issues. We will stick together to make sure that DC residents are getting back to the doctor for their annual exams that they have skipped during the pandemic. We will stick together to ensure that our families are getting vaccinated and that we are clearing up misinformation about vaccines, especially for women who are pregnant and want to get pregnant. Let's be clear, the evidence is clear. The vaccine is not only safe for pregnant women or breastfeeding women or those who want to become pregnant, but it is recommended by public health officials. And we are going to stick together in giving all of our families in Washington, D.C. This is the whole reason why we're here, and the whole focus of our government is to look at our vast resources and talents across the city and ensure that every single one of those resources, human resources, financial resources, is being strategically invested to give every single person a fair shot in Washington, D.C. This discussion is hugely important in that regard, and I invite you to stay tuned to the important panel discussions, the breakout discussions, the affinity groups that form around important issues related to healthy babies and improving our experience in Washington, D.C. Thank you, everybody.
Ladies and gentlemen, please welcome Dr. LaQuandra Nesbitt, Director of DC Health.
Hi, I am Dr. LaQuandra Nesbitt, the Director of the District of Columbia Department of Health, and I am excited to welcome you to Mayor Bowser's 4th Annual National Maternal and Infant Health Summit. Throughout the COVID-19 pandemic, DC Health remains committed to our perinatal health and wellness goals. Community partners offering direct service programs such as WIC and maternal, infant, and early childhood home visiting programs were able to pivot from an in-person only model to a virtual model to meet the needs of families. With the use of technology and telehealth, continuity of these critical services was maintained. Consistent with the recommendations of the Mayor's Commission on Healthcare Transformation, we've invested in the creation of an initiative that connects community-based outpatient prenatal care providers for district residents living in Wards 7 and 8 to the city's hospital-based labor and delivery programs for more seamless and integrated care. We continue our focus on preterm birth reduction and on improving the health of women before they become pregnant to address the leading causes of infant death in the district. And we're doing this with strategic partners such as MedStar Washington Hospital Center, Unity Healthcare, Community of Hope, and Howard University. Notably, we have worked collaboratively with Howard University to launch the development of a Center of Excellence for Women's Health that will leverage and foster the university's cross-disciplinary expertise. During the summit, you'll have the opportunity to identify and share best practices for pregnant women, babies, and families in DC, given our local context and unique assets to promote gender-inclusive and patient-centered sexual and reproductive health care, and to think deeply about our shared district values and how to ensure that every baby born here from every neighborhood celebrates their first birthday and beyond and can thrive into a healthy adulthood. Over the next 2 days, you'll gain insight on how we in the district continue to ensure the health of women, babies, and families through panel discussions and community-led breakout sessions that were developed to connect district residents with resources, both locally and nationally, as well as familiar support, so everyone achieves their optimal level of health. A stimulating and inspiring agenda has been planned. So I want to welcome you once more, and I hope you enjoy this year's National Maternal and Infant Health Summit. Thank you.
And now we will hear from our DC Hope presenter partner, Sibley Memorial Hospital and Johns Hopkins Medicine.
Hello, I'm Carolyn Carpenter, President of the National Capital Region of Johns Hopkins Health System, which many of you know includes Sibley Memorial Hospital and Suburban Hospital. I am deeply honored to bring greetings to you today in recognition of Mayor Bowser's 4th Annual Maternal and Infant Health Summit. Childbirth is one of the most memorable times in the life of a family, and all expecting mothers and fathers deserve the right to deliver a healthy baby. No child should be at higher risk of birth complications. No mother should be at higher risk during childbirth simply because of the zip code where she lives or her skin color. Sadly, across the District of Columbia, this is not the case. Black mothers are more likely to die during childbirth across the district, and Black and Hispanic babies have a higher chance of preterm complications than non-Hispanic white babies. Mayor Bowser's Maternal Health Initiative is changing this harsh reality by bringing together stakeholders from across the district in very unique and innovative ways. The Mayor's initiative brings together the depth and breadth of the DC community's most critical resources for maternal health, from preconception to post-delivery. The combined effort is helping to create health equity and improve the quality of maternal care for women all across the city. Johns Hopkins Medicine is not only honored to be part of the conversation, we are committed to being part of the solution. We are partnering with communities in Ward 7 and 8 to invest in citizen-led, human-centered maternal health care innovation. We are doing the work that we need to do to ensure that Sibley Memorial Hospital is more accessible to all women in the district who wish to have their babies with us. And we are committed to doing our part to help improve the maternal health experiences and outcomes for all women in the District of Columbia. Thank you for your time today, and I look forward to the insights and solutions that emerge as part of this very critical community conversation.
Please welcome to the stage Panel 1, Maternal and Infant Health, where we've come from and where we're going. Our moderator serving today is Stacey Brabor, Senior Vice President of Public Policy and Government Affairs, March of Dimes. The Honorable Muriel Bowser, Mayor of Washington, D.C. Angelina Spicer, comedian, actress, and activist. Dr. Robin Jones, Senior Medical Director, Women's Health and Office of the Chief Medical Officer, Johnson & Johnson. And Dr. Layla Alquito, Attending Physician, Children's National Division of Neonatology and Children's National.
So good afternoon, everyone. I am pleased to be here today with each and every one of you and everyone here, and have the opportunity to moderate this conversation with such a distinguished panelist. At March of Dimes, advancing the health of the mom and the baby is at the core of each and everything we do each and every day. We do this through our programs, we do this through our research, and we do this through, most importantly, our partnerships. Our nation continues to face a maternal and infant health crisis, and one that has been compounded by economics, as well as the health impact of COVID-19. Do you know each and every day in the US, we have 2 women who die from complications of childbirth and pregnancy, and 2 babies that die every 2 hours, every day. And far too many, and far too much, and too often, those are moms and babies of color. We've made significant progress here in the district, and I'm sure that everyone in here and here on this panel that joined me will agree that there's still a lot of work that we all can do together through partnership. We've made significant progress, and let me share with you the latest report that comes from the report card that is published by the March of Dimes annually, specifically for Washington, D.C. I'll share two statistics with you. Premature births in the district have improved from a high of 11 per 1,000 live births a decade ago to just recently last year, 10.4. The second statistic, white women have a premature birth rate of 9.4 per 1,000, while the number for African Americans is even greater. It's 13.4. Now, in addition to that, there are many challenges that we face and that women face in regards to being able to have access to not only affordable, but access to prenatal and maternal care services. They live great distances, and because they live great distances, it is difficult for them to be able to go and travel to get the maternal care and the prenatal services that they should have. And what I'm happy to share with you is that today, here in Washington, D.C., and also in Southeast Ohio, March of Dimes has partnered with Reckon Infa to put together a package of profiles and bond of a launch of programs that we're calling Better Starts for All. And together, through this program and partnering with March of Dimes and Reckon, together we're bringing support, education, we're bringing clinical care to those pregnant people and new moms throughout the area. And we're doing this creatively. We're calling it Moms and a Baby Mobile Health Unit, health centers. These are health centers that travel throughout the community. So we're going to the community so that we can bring these services to these women. We'll share more about that with you at the Mayor's Summit, her post-event, which is a Mommy Mixer. And that Mommy Mixer is next Monday, September the 20th. And it's going to be at the Satellist Southeast location. So hopefully we'll be able to see all of you there. Again, the Mommy Mixer. Now, I'm excited to jump right into this conversation and talk to our distinguished panels. And so let's begin. Let's talk about how we can work together. So Mayor Bowser, my first question is going to go to you. We hear so much news about maternal mortality and morbidity across the United States. What is the status of maternal and infant health in the district, and what are some of the challenges?
Well, thank you for that introduction, and also thank you for the wonderful work that the March of Dimes is doing in the district, not just in the time that we've been hosting this summit, but you must be 100 years old, the organization. So we appreciate all that the March of Dimes is doing, but also recognizing the need to pivot in this space and to make sure that we're talking about the issues that are affecting Black and brown communities across our country, but also as a nation. Why are we behind other developed nations in the world in the experience for moms and babies? So you've talked about some of the numbers that we know impact the health of moms and babies, prematurity being one of the big ones. And we too follow the ratings of live births and how we're faring in the city. And any baby, we want to be able to live, like Dr. Nesbitt said, through their first birthday and beyond. So one child lost in childbirth or one mom negatively impacted in childbirth is one too many. We have seen, as you've noted, since 2007, the mortality rates be halved to the positive, and that's a good thing. So where we were at over 13 per 1,000 births, we're now, I think, somewhere at around 7 mortalities per 1,000 births. So that's a good thing. You also mentioned how stubborn the number is to come down. And so all of the things that we're doing, we have to stay focused on, because over time and compounded with each other, we know that impacts the health of moms and babies. We have been very focused, as you've heard in some of the videos, on the prematurity number, moms having access to care from the earliest point in their pregnancy and after their pregnancies, to make sure that we can pour into a healthy start for our youngest Washingtonians, and we'll continue to do that. But more largely, in what we focus on is not just the health care part of healthy babies, but all of the social determinants of how healthy women will be when they go on their pregnancy journey. And so that is a huge part that we'd like to talk more about, how affordable housing is health care, how having access to healthy food is health care, and how women having a supportive home environments with good paying jobs and access to leave is also part of how to have healthy babies.
Thank you. And Ms. Spicer, let me ask you this question. How does your story and work add more to this conversation around maternal and infant health?
Well, thank you so much, Mayor Bowser, for having me. I feel like the unicorn on this panel because I don't have a medical degree. I have a BFA from Howard University, so big up to HU. Yes, absolutely. But I am a stand-up comedian. I'm a stand-up comedian, I'm an actress, I'm a social media influencer, and I planned to have my baby, to answer your question. I planned to have my daughter 6 years ago now with my husband. I mentioned that I'm married because a lot of times people assume the black women don't have husbands. But I'm married, my husband and I planned on having our baby, but we did not plan on me having a perceived traumatic birth, nor did we plan for me to get severe postpartum depression. After I had my daughter, I thought I did everything the right way. I went to all of my prenatal visits. I had a good relationship with my OBGYN. I had a stable relationship. We're homeowners. You check off the list. We thought we did it in the right way. We planned it. But I was so blindsided by just the physical pain that I was in. And I won't go into the gory details. You got to come to the comedy show for that. But I was just so blindsided by the pain and how wrecked my body felt and the responsibility of now being someone's mother. And people always say, oh, no one can prepare you, no one can prepare you. No, ma'am, they can't, okay? And mentally, I was just, I felt like my mind left the building. And I say that jokingly, but seriously, I felt like the world turned gray. And where I'd usually seen things in vibrant colors and funny, and I had just lost my sense of self. I describe it as I felt like my old self died. And I was mourning my old life. And I tried everything. I had a relationship with a therapist, so I continued with my therapy. I started going back to church again. I tried to pray it away, because I'm black, and black people tell you, pray it away. So I tried that. I tried speaking to the women in my family. I tried, turning to social media groups that I'm a part of and my social connections, and nothing helped. So ultimately, at 8 months postpartum, my therapist recommended that I check into a psychiatric facility for treatment. And that was the best gift that she or anyone could have given me, because I was able for 10 days to check into this magical facility that felt like a vacation, okay? It felt like I was at Sandals, all-inclusive to the Bahamas. I didn't have to wipe a butt. I didn't have to change diapers. I didn't have to look at my husband's face. I could sleep, I could take a shower, I could comb my hair. I was like, ooh, old Angelina is back. She's here. So that was the gift that I didn't know that I needed. And I'm so thankful that I had access to care, that I had a therapist who checked in on me and followed up and made sure that I was healthy and cared for. I'm thankful that my mom was able to use FMLA and literally grab her purse and hop on a plane to Los Angeles, where I live. And she stayed for 4 weeks to help my husband and I transition. It was just such a beautiful gift. So now I'm really on a mission to normalize the conversation around maternal mental health and normalize the conversation about what it's really like after you have a baby, okay? Because it's not in a book. It's not in a manual. It is literally the stories from our experiences that will really help push this conversation forward. So I call it the #postpartum revolution. We've been on a national tour. I've met with lawmakers, and I'm really just looking to push the needle to normalize this conversation by way also of a documentary film that I'm working on.
Thank you.
Thank you.
And so now I pose the question to you, Dr. Jones, and as well as to you, Dr. Quito. As practitioners, what is missing from the narrative about the state of maternal and infant health?
I think Mayor Bowser touched on it when she referred to those social determinants of health. It's where we're born, where we grow, where we live, where we work, where we play. Every one of those parameters impacts our wellness and the health care we received. Let's talk about where we live, the environment. If you live in the inner city and you don't always have access to electricity, don't always have access to water that may be lead-free, don't always have access to transportation because you don't own a car and you have to get to the medical center that maybe is only 10 miles away, but you don't have access or car fare to get there, that's an access issue. And that's due to your environment where you live, to the, I call it right now, the eternal racism that exists here in the United States, the haves and the have-nots, no pun intended, and recognizing that each one of these really determines how well we can be. Where you grow, and when I say grow, it's where you're educated and whether you have access to it or not. And we're here in an urban environment. The same thing impacts those in a rural environment who don't have the economic access that they should have to be able to be successful and have a healthy lifestyle and provide the same for their families. And each one of those parameters impacts a woman's ability to have a long, healthy pregnancy. And Mayor Bowser referenced what's going on in this country. The United States is the only developed country in the world that has an increasing maternal mortality rate. It has the highest mortality rate for mothers more than any other developed country in the world. Think about that for a minute. Aren't we the richest country in the world? How can we possibly have the highest maternal mortality rate? And who's being impacted? Women that look like me. We are 3 to 4 times more likely to die related to a pregnancy than white women are here in the United States. And it's certainly worse. Those numbers get higher depending where you live in the United States. And you think about that being, okay, that must be deep south. It can't possibly be in a developed city where I live or a state where I live. Well, within those top 5 states, certainly those, the usual players that you might think because of, where people live in a more rural habitat, such as Louisiana and Georgia, but New Jersey's in that top 5 also. And there are other major states on the East Coast that are not far behind. That should not be happening. And in order for us to really address that, it is about advocacy. It is about political change. And there's a number of ways to approach that, and I know we'll be talking some more, so I'll leave that till later.
Thank you. I think everyone has actually answered the question already, so thank you. Bye-bye. I'm going to leave now. I first want to thank Mayor Bowser and her team for putting together this excellent summit. It's a great opportunity for us to come together and discuss these issues. It's truly an honor to be here and to represent Children's National. I think you asked an excellent question about what's missing from the narrative. I 100% agree with what's been said before. I think one, as Ms. Spicer said, the stories are missing. Often we're bombarded with a lot of statistics, but just to humanize it, it's so important to hear stories like that were shared. Secondly, I agree the social determinants of health definitely is something that should be emphasized. And whenever I'm bombarded with these statistics, it's important for me to hear the next step, which is the why. And that is something that I think is often missing. We hear the stats, but rarely are there recommendations or proposals or ideas, hypotheses of why we think some of these issues exist, particularly when it comes to the healthcare disparities that we see that affect Black and brown women and babies. I think it is important for us to recognize the role of systemic racism, things like implicit bias as well, and how they all may play a role in some of these negative health outcomes that we're seeing. I'll take implicit bias as an example, and this is that idea that we act and we do things based on subconscious stereotypes that we have. And in the healthcare arena, how does that play out? That could be me as a physician. I could recommend one treatment plan to a particular person, and someone else who has the same condition but looks differently, they're from a different background, different race. Subconsciously, there's some stereotypes there that I have, and I recommend or withhold a certain treatment plan for that person. That's how implicit bias plays a role in healthcare, and undoubtedly we know that this has some effects on some of our health outcomes, particularly when it comes to mothers and infants. So when I read these statistics, when I hear about the disparities that exist, I'm really looking for an answer. I'm looking for the why. And I think it's really important that we look upstream and some of and have those issues kind of addressed. So, thank you.
Thank you. So the second question, and actually all of you addressed it, and Dr. Jones, you spoke to it as well. And so I'm going to phrase the question, and I'm going to start with you, Dr. Akito. It is, we know that maternal infant health isn't solely clinically determinants. And I think Dr. Jones spoke to it in terms of just social determinants as well. Dr. Akito, could you share a bit about factors impacting neonatal health outcomes?
Sure, absolutely. I mean, I think as mentioned before, the social determinants of health play a big role in the outcomes that we see, not only for adults, but also for the neonates as well. As was mentioned, prematurity is the leading cause of mortality and morbidity for infants. So when we think of that, we think of what are the causes of prematurity. As mentioned before, it is these outcomes are closely and intimately related to the health care and the health that the mother has, the birthing parent's health. It clearly has an impact on rates of prematurity. So when we're looking at this, we have to decide, are the mothers receiving high quality and early prenatal care? Even before that, looking even more upstream, we know that a mother's health, even prior to becoming pregnant, plays a role in her pregnancy and the outcome of it. So when we think of prematurity, we have to think of the mother's health, the birthing parent's health. Moving a little bit forward, we know that statistically where a preterm infant is born has an impact on their outcome as well. So when we have to consider the quality of care that's being provided at the hospital. So where you're born plays a role, and that is part of the social determinants of health as well. Thereafter, we look at the environment that an infant goes into. And when I say environment, this is all-encompassing. So we're talking about where the child lives, the physical space of where the baby will be. What are the sleeping habits of the baby? We all know that safe sleeping habits is intimately related to survival of infants, and we really need to practice safe sleeping habits. What is the air quality? Is this baby being exposed to secondhand smoke or air pollution? We know that all of these issues related to the social determinants of health impact the outcome of infants. When I think of environment, I think about the parents, the mental health of the parents. This in itself also will affect the development of the child and the future for that child as well. So there are a number of factors. I think that we can be here for an hour really listing off all of the issues that can impact a neonate's health outcomes, but the umbrella of it is certainly the social determinants of health certainly need to be addressed.
Thank you. And Mayor Bowser, my question is to you. Can you talk a bit about investments that your administration has made here to overcome birthing for people, babies, and their families?
Well, as I was listening to the doctor go through that long list, I was kind of ticking off in my head since we've been having this discussion, we all like to see each other, that's fine, but what we really want is to make sure that we're following up on what we're learning, and we're using, just the vast resources of our government to make things better. We're 700,000 people who live here. We just approved a $17 billion budget. We have 96% of our people have health insurance. I think that makes us number 2 in the nation for people who are insured. And we have healthcare facilities in every part of our ward. Of our city in all 8 wards. And so sometimes when we talk about the kind of the health outcomes and the health disparities that exist in our city, I literally want to pull my hair out. Because we invest so much and we want people not only to take advantage of it, but for their interactions with the system to be effective and for the outcomes to improve. That's all of what we are in this for. And so the one investment that I'll talk a little bit more about yesterday that I know is different from when we started having this discussion is a quality home visitation that may address what Ms. Spicer is talking about, because I appreciate her sharing her story, because it is, as everybody says, it's wonderful to have a baby, but I think that everybody has probably also had the experience of like, oh, what am I doing? So a lot of people have, let me put it that way. And so that conversation can happen between a new mom and a family and a professional who's been to that rodeo, who can assure a mom and a family that these resources are available to you. And they're vast resources that can be available. It's also important for us to emphasize, when we started having this conversation, we were seriously concerned, and it was the decision of Dr. Nesbitt that the quality of care being delivered at one of our hospitals for delivery and new moms wasn't up to where we needed it to be. And we had to transition away from it. And we spent the rest of that time making sure that moms and families, expected parents, were connected to both the specialized care and the prenatal care that they needed. But we also were very focused on how we were going to bring those services back to Ward 8. That's why we are so excited that we will be opening our hospital on the schedule that we have announced, that we have an outstanding partner, that the operators of George Washington University Hospital are going to operate the hospital at the St. Elizabeth's campus. And today we've been talking about Children's National, who's been affiliated with United Medical Center for many, many years, is going to operate the emergency services and the neonatal services at our new hospital at St. Elizabeth. So all of those things are part of the puzzle. But I don't think the doctors would mind me saying this, that they don't really want to see the kids in the hospital. Right? You don't want to see them in the hospital. So the system of care that we're building so that people can take advantage of services as they're thinking about having a baby and beyond are going to be very, very important for us.
And you can see everybody nodding their head. This is great, Mayor. This is great. And I will pivot and take the next question to you, Mrs. Spicer. Your work combines advocacy and comedy. Tell us more about how your legislative work has allowed you to support maternal mental health.
Well, I call myself an accidental activist because I was fine cracking jokes. I was fine going to comedy clubs, working TV shows and doing my thing. But again, I was just so blindsided by this experience that I was like, someone has to say something. Somebody's got to do something about this, because in my case, with postpartum depression, severe postpartum depression and anxiety, I felt like it could have been prevented. And I felt like the severity of my illness could have been prevented. So my goal, honestly, was to free moms who are scrolling Instagram, who are on Twitter, who follow me on TikTok. You know, my goal was just for them to see themselves in my experience. But an organization approached me after seeing some of my content online and asked if I would join them on a legislative visit up to Sacramento, California. And I went, I met with lawmakers, and I was like, this is my jam. I was like, this is my jam. Okay, I can actually go into, thank you. I can actually go into an office where people are not expecting to hear jokes, crack them up, and then get them to like do what we want. So I met with a bunch of legislators in Sacramento, California, and I was a part of a team, and we helped pass 3 new laws, 3 new bills of legislation to help the mamas. I was like, yes, this is it. So now in California, moms have to be screened. I'm like, why is this rocket science? Why do we have to beg and plead for a mama to be screened by her health professional? So now mothers in California have to be screened. They have to be screened during and after pregnancy. If someone had screened me when I was getting one of those NSTs, oh Lord, you could have saved me a trip to the psych ward, honey. That's right. But that's all right, because it was fun. But anyway, the second piece of legislation that I helped work on was to train physicians and labor and delivery staff on how to actually implement these screenings. And I work with Cedars-Sinai Hospital in Los Angeles, Los Robles Hospital in Los Angeles. Now I work with doctors and stuff. I'm like, okay, this is kind of cool, right? And the third piece of legislation was to collect the data and have a resource center or a database to refer women to when they show signs that they're in crisis or that they need additional care. So those were the bills, and now I am on what's it called? I want to. Y'all gave me a mic. Okay, so now I'm screaming at everybody. I'm like, okay, somebody check on the mamas. We need this kind of legislation across the country. So now I'm working with Congresswoman Lisa Blunt Rochester on her Momnibus package, which I know the March of Dimes is a huge supporter of. And I really want to work on federal legislation to get the same level of care that we have in California across the country. It's not fair that mamas in Mississippi or in Louisiana are not being screened. It's a simple thing. So that's what I'm doing with the legislation piece. Thank you. Thank you, Mayor Bowser. Thank you.
Thank you. Thank you. Our next question. If COVID-19 has taught us anything, it is one, the timeliness of accurate public health information is so important. And 2, the trust in public health can save our lives. We've learned from this pandemic, what can we learn and what have we learned from this pandemic that we can use to improve the outcomes for our moms and our babies? And Mayor, I'm going to direct this question to you first.
Well, let me see if I'm on. Hello? Nope, I'm not on. Okay. I love that question because we're coming out of, I'm saying we're coming out because I believe that we're coming out of this with COVID. Yes, we are. And, but it's been 18 months, and it's been, if you talk to anybody who's sat in my seat before, and I know our medical professionals, I had no idea that we would be here 18 months. No, you know, when we looked at other pandemics, sometimes it's 2 years. I just didn't believe it. But here we are. And I say this, when we talk about public health officials as a mayor, I knew that I had a great department in DC Health. I did know that. I especially knew that we had a great director. But they have performed in a way that is so exceptional that DC residents should be extremely proud, and I know I'm proud as their boss. So I want to thank DC Health. Let's give them a big round of applause. But DC residents have also performed exceptionally. They believe in science. They trust the government. They verify what we say. But they have followed public health guidelines. And as a result, I firmly believe that our first goal was to flatten the curve, which they did, which gave our medical professionals the ability to have hospitals prepare the PPE they needed to continue to serve people who are having babies, at the same time serve people who are suffering from COVID. So we were able to do that. So I know that all of the work that we did, we were able to save lives. Another group of government folks that I want to highlight and acknowledge is our communications teams, not only in the health department, but for people who work for people like me, like mayors and public officials who were out in front every day talking about scientific information. And made it possible for us to do it in a way that was understandable. So I will give a big, big shout out to EOM Comms and all of the comms professionals in DC government. But we learn things about public health, but we're also applying those lessons in other areas. We are applying lessons learned to gun violence, for example, where we've set up an emergency operations center where the public health officials have been supported by other outstanding public service in the government to get work done. So that has been a very, very important lesson learned from COVID, how important it is when there's not an emergency to have outstanding people preparing for the emergency when it happens. And that's what we had in DC Health. But also having the government being able to pivot on a dime to support our lead agency in that example. But the other benefit, I think, that our medical professionals put on display is that interventions work. The thing that COVID showed us is that we can model it. We can define an intervention, whether it's mask wearing or social distancing or hand washing. We can apply it, and we can watch what it does to the curve. I firmly believe that that is applicable to just any kind of public problem. And sometimes the curves move slower, or sometimes we can literally watch an intervention and 20 days later to see what it does to our experience with COVID. And how we talk about it consistently, forthrightly. And I have learned as mayor, and I appreciate the support of DC residents and businesses in this, but we told them the truth, we told them what they needed to do, and they did it. And we had the support of the medical community in saying, this is the science, this is what works, and we're going to show you how it works. And I think that's applicable in so many ways.
Thank you. Dr. Quito, I'm going to pose this question to you. The Children nationally is a unique position to address maternal, mental health, along with the care of newborns and young children. How do you work with the care team to ensure families are able to make the best health decisions for themselves?
Thank you for this question. And you're right, as a neonatologist, I care for critically ill newborns, but I'm a pediatrician at heart. So my patients are the kids or the babies, but any pediatrician will tell you that the parents are also your patients to some extent. And that looks different in different settings. But in the NICU in particular, it is our duty to really help to support parents because they are in crisis. We expect to have a well and healthy newborn baby, but the parents that we're interacting with are in crisis mode because their infants are sick. So I have the privilege of working with a a nice team of physicians, nurses, social workers, and psychologists to really help to address the mental health of our parents in the NICU. We started by screening parents because, as I said, these parents are at risk, and we know that they're at risk because they're in crisis. So we found that in our NICU at Children's National, 1 in 3 parents or 3 mothers are experiencing elevated symptoms of depression. And just to put that into context, in the general public, we usually say about 1 in 10 mothers will experience postpartum depression. In the NICU, it's 1 in 3. So that's a lot. That's a lot. And we know that even at the time of discharge, about 45% of our mothers have elevated symptoms of depression. One of the lessons that I quickly learned during my training at Children's National is that with screening, there are some people that are getting missed. With screening for depression, it's complicated. I know it's easy, but it's also complicated at the same time because you want to be able to respond immediately if someone is in crisis. So at the moment, our system is to screen parents that are there in person at the bedside of their infant. But that in itself has some iniquities, right? We know that the hospitalization is long. There are some parents that just cannot be there all the time at the bedside for a number of reasons. These social determinants, like we talked about. Some parents have to go back to work. They don't have alternative child care. There are transportation issues. So there are some parents that are getting missed. Our goal right now as a team is to really figure out how to get to those parents because they too are certainly at risk, even, and I would dare say at more risk for having depression than those parents that are at the bedside. So at the moment, our team is partnering with a company to leverage technology to help to address this use. So we've had some small funding to pilot a partnership with a company called Mama that will allow us to use text message to screen our parents for depression, to provide referral, care coordination, as well as ongoing psychoeducational support. So with that is one of the steps that we're taking at the moment to see how can we leverage technology to expand our screening. In addition, we also had small pilot funding to bring a psychologist into the NICU because that in itself is a barrier. We screen and then we refer parents outpatient, but the follow-through with that is difficult. So by having a psychologist in the NICU, it's a one-stop shop. The parents can be there with their parents and also get the therapy, and we're able to leverage technology with this so that we can use telehealth to provide the support to parents that can't be at the bedside. So overall, if we can improve the mental health of our parents in the NICU, it will not only be beneficial for effective shared decision-making with the parents, but it's also very important for once our babies are discharged. We go through a lot of work to really improve the survival of our ill infants, but we are just a small part of that child's life. The parent is really who is going to be there to take care of that infant once they're discharged. So addressing their mental health early and effectively is part of our duty in the NICU.
Yeah. And so as we come to a close, I have one final statement, and then I will pose a question to each of you quickly. While we know that the awareness of maternal and infant mortality rates is crucial, we also know that we must move beyond awareness to action, and that is moving towards action. As we close, the question I pose to all 4 of you, what does it look like to move to action to improve outcomes for moms and babies? And Mayor Bowser, I will start with you.
Well, I want to say a little bit more about advocacy. We heard Ms. Spicer talk about her advocacy in California, and as I was sitting here, I was thinking that we're in Washington, D.C. This is a national summit, and our Congress right now is not taking action on something important to moms in healthy families. And there are probably many things. I know the March of Dimes probably has a long list that you want to move forward on. But the president's infrastructure bill focusing on families is one such thing that needs to move because it will ensure that people can take care of their families when they need care. And that child care providers, elder care providers are better trained and better paid. And one thing we know that moms are doing, if you're a mom like me, you have a little one and you have senior parents, and they both need care. I'm in that sandwich generation where I'm trying to figure out both ends. We know that we are relying on people to do some of the most important work in our families, and that's to help the little ones and help seniors when they need more help after they've spent their whole lives working. Why shouldn't people have the dignity of being cared for in their own homes? And so we need to really be focused on making sure we're making life better for our care providers. So that's one piece of action that we need to continue to take. I also focus a lot, we have a policy in the district. Certainly we follow a health in all policies that the Department of Health makes sure that all of the agencies, no matter what they're thinking about, are thinking about the health of our residents. But we follow also a policy called Housing First. And largely that term is used when we're talking about ending homelessness. But it's so important when we're talking about any health outcome, because people can make a lot of better decisions when they have safe and affordable housing. When they have great housing that's close to groceries, then they can make better healthcare decisions. When we have housing in parks and rec that are less than a mile away from every resident is less than a mile away, we can have healthier outcomes. When we can make sure that we have the proper inspectors to go in to make sure that there's no lead paint, we know that our children can enter school healthier. When we can expand, like we've been able to do, opportunities for people of all incomes to have affordable summer camp opportunities, we can have healthier families. So those are the actions that as we go into a new budget cycle, where we're investing so much in early child care, so much in affordable housing, so much in quality grocery in all parts of the city, I know that those things will compound. We'll have healthier women, healthier moms, and healthier babies.
Here we go. Mayor Bowser, advocacy, I think, is the key action step in moving the needle, pushing the conversation. Like I said, I'm an accidental advocate, activist, but we can all do one small thing to help with the health of mothers and babies, particularly the mothers, because that's where my heart lies. Mostly because if mom is not healthy, no one's healthy around her. You know, when moms thrive, the families thrive. So it's important that if we see something, to do something. You know, I'm using my art with comedy, with my own story, with a documentary film. But it's important that if we see a mom struggling, be it at the grocery store, at the gas station, at the car wash, to help a sister out. It is that simple. You know, it's important that moms also see themselves in us as we move throughout the world. So sharing our experiences. You know, when I first had my daughter, I felt like everyone lied to me. I felt like everybody was a liar, that I'd been duped. You know, and that was mostly because the women in my family hadn't shared what their true experiences were like. And so it's important that when women around us who are close to us have babies, or even thinking about babies, having babies, that we pull them aside and say, okay, it was like this might happen. And it's not necessarily giving advice, it's more so advocating for what the experience might or could be like, so that they're not left blindsided or feeling like, oh, this is just a me thing. I also advocate for people to take therapy. Therapy is good, sisters. Black folks, therapy is good. It's a good thing. Get you a therapist. And go to the psych ward. It's a beautiful place, people. And it is covered by insurance, okay? $35 a day. Check in. Those are my actionable steps. Thank you.
Thank you. Thank you. And Dr. Jones?
So, as I've been sitting here listening, you know, I'm an obstetrician gynecologist by training. I'm clearly a black woman, and I've had the opportunity to have at least half my career working for Johnson & Johnson. And we have at least 3 projects that I need to share. One is the Equitable Maternal Health Coalition, where we partnered with the American College of OBGYN to establish a coalition, which is now led as a nonprofit by the March of Dimes, to really look at advocacy and policy and where we can make a difference. We were one of the first corporations to support the Momnibus Act. And on a state level, we have a toolkit for state legislators to be able to get their states to create the Maternal Mortality Review Committee that will provide the data that we need to take action. You have to have data to act upon. And the Maternal Mortality Review Committees, which are now required for every state, funding's not always available, but the information on how to get it up and running is something that we have in our toolkit. Another project that we have is called the Georgia Project. In my conversation earlier, I mentioned, you know, the states that have the highest maternal mortality rate here in the United States. Georgia has remained in the top 5. It's been 1, it's been 2, but it's still in the top 5. There we have a partnership with several academic institutions, including Morehouse School of Medicine, Emory, Georgia Tech, Georgia State. We have an advisory panel, and we are also partnering with another corporation, with Walmart, to provide blood pressure cuffs and things that a woman would need to be able to monitor herself during a pregnancy. As part of the Georgia Project, and we're also partnered with I believe it's the Black Mamas Coalition there, we are also looking at things like telehealth and technology and how we can bring them to this community and how they can benefit. And everything we do is research-based. That's who we are. So whenever we're doing something, we're collecting data that can be used. And then third, but not last at all, is a project that I'm personally leading, which is called the Hack for Equity. And it's a hackathon for the health equity of Black mamas in Georgia. What's so powerful about it is that it's not just a technology solution. And I know those of you familiar with hackathon, that's how you always think of that word in hacking. It has to be tech. But it's also an idea-thon. There will be winners selected. There will be cash prizes awarded. Participants are anticipated to be professionals, students, and when I say professionals, it's entrepreneurs, it's public health professionals, it's medical clinicians, it's academicians, and then of course, as I mentioned, it's our students. And the solutions to the problems are problems in Georgia, but that can be extrapolated across the United States. And our entire Georgia project really is seen as a pilot as to how we can make change and how we can impact the policies and the way healthcare is provided here in the United States for our Black mothers. That is so important because mothers lead everything, and people who do the mothering lead everything. And we want to keep them healthy. There is no reason that the United States, as a Black woman, you are more likely to die from your pregnancy than any other race or ethnicity here in the United States, and just in general, any other developed country in the world.
That was very well said. Hard to follow that. I guess I'll take it from the perspective of a clinician. How can we go from awareness to action? And I really encourage all of my colleagues or anyone that has interface with patients at the bedside. I think it really starts from within. I think we need to ask ourselves some hard questions. What role am I playing in perpetuating some of these health disparities? I think we really need to acknowledge and recognize, identify our own implicit biases. What decisions am I making that is making the issue worse? There are actual tests that you can take that will help uncover some of your subconscious stereotypes. I encourage all of my colleagues to take them because it's very telling. And then constantly recognizing that whenever you're in that scenario as a clinician, recognizing your biases and really encouraging yourself to make decisions based on your better clinical judgment as opposed to your subconscious stereotypes. I think as a clinician, we also need to take the onus on us to build trust with our patients. When there's no trust, our patients are not going to follow through with the recommendations, which will have long-term impact on the health outcomes. I think the clinicians, we need to take the responsibility to understand the historical context of this mistrust. It's not up to the patient to explain it to us. We can do that homework. Google is available to everyone. So you can Google it. Why is there mistrust in certain communities and the healthcare system? I think that is up to us to really build and have an open communication with our patients. So certainly I think it's one thing to be aware, it's the next step to take some actions. And I think that these are some really important steps that clinicians need to take. And I think just overall as a healthcare system, we need to continue to encourage these types of dialogue. As we said, the social determinants of health really have a big impact on many of these health disparities that we've discussed. We need to get out of the walls of the hospital and really build on these partnerships within the community. And I just want to put that plug out there that at Children's National, we're committed to this work. We're open to these partnerships, and if anyone is also equally like-minded and ready to get to work, we are too, as well at Children's.
Thank you. And so, Mayor Bowser, what I'll say to you is thank you for your leadership. Thank you for the work that your administration is doing in this space. We commend you. I want to thank our wonderful, distinguished panelists for their comments. Everyone has kind of shared with you where we are, what we can do, and the action that everyone in this room can take. Thank you all for joining us today.
I just wanted to make an announcement that we will transition to our next panel shortly. So we hope that you all will stick it out with us as we take this quick photo.
I'm Muriel Bowser.
Thank you, guys.
Good afternoon, everyone, and please welcome to the stage Sally Allen, head of J Labs at Washington, D.C., along with John Falchicchio, Deputy Mayor for Planning and Economic Development.
Well, good afternoon, everyone. I'm John Falchicchio, and you're probably wondering, what is the Deputy Mayor for Planning and Economic Development doing on the stage? Well, Sally's going to help me talk to you a little bit about, we heard a lot before on the panel before about how you have to have advocacy, how you have to have interventions. And what we're going to talk a little bit about is innovation and how you take new ways of approaching problems that have been with us for a long time. So Mayor Bowser in 2017 convened with the governors of Maryland and Virginia to go to Toronto, Canada. And one of the stops that we made with Children's National was at J Labs, Johnson & Johnson's innovation incubator. And we went there to see what J Labs is all about and to ultimately try to get a J Labs somewhere in the region. And so we're really excited that in 2019, we were actually able to announce with Mayor Bowser and Children's National that J Labs would be locating right here in DC at the Children's National Innovation Campus at Walter Reed. Now, 2 years later, we're here.
We are open for business.
We're open for business. So I like to say, you may hear me say it often, DC is open, J Labs is open. And so what we wanted to do at DemPed was to work with Johnson & Johnson and Children's National to put together a challenge. We've talked a lot about health disparities today. So how do we actually address health disparities through innovation? So Sally, tell us a little bit about J Labs, and then we'll talk about the Quickfire Challenge.
Yeah, first, and let me thank you for having us here. I think this is an amazing and important summit. We're thrilled to be part of the summit and talk about hard topics like maternal mortality, also some other health issues, which was part of this Quickfire Challenge. But before we talk about the specifics, let me tell you a little bit about Johnson & Johnson Innovation and what we're doing here at Washington, D.C. So as you alluded to in 2019, we announced our partnership with Children's National as launching and anchoring at their new research and innovation campus in Northwest DC. We thought it was incredibly important to be here in Washington, DC, to bring a light to the need for more pediatric innovation, but also this incredible strategic location to incubate companies, to support entrepreneurs and early stage companies. So Johnson & Johnson Innovation J Labs is a global healthcare incubator. We launched and opened our 13th here in DC. We opened for business in April this year. And what we do is support early stage companies and entrepreneurs with an incredibly easy turnkey access to wet lab research facilities, medical device innovation labs, and we surround these entrepreneurs and companies within a global ecosystem of support and resources, access to capital. So we are incubating and supporting all over the world over 700 companies working in pharmaceuticals, medical device, and consumer innovation, as well as digital health. And so, as I mentioned, we opened in April. We've started onboarding companies at the new Research Innovation Campus, which is an incredible ecosystem itself. The idea that entrepreneurs and companies can also sit on an innovation campus, work directly with Children's National's research institutes, cross-pollinate, and drive more partnerships.
So taking the concept that we first saw in 2017, 2019 was the announcement, 2021, here we are, you're open. So what can we expect to see a year from now out of the J Labs here in DC?
Yeah, that's a great question. So as we roll companies into J Labs, many are at different stages. We're supporting not only entrepreneurs here that have started their own business within Washington, but also bringing in companies from outside of DC. A great example is a company we are bringing up from Alabama. Actually, they're here. They want to expand and scale their business. They want to reach communities like the district. The company's called Acclinate. They're working on driving diversity in clinical trials, and they have a hashtag now included platform, incredibly important. We want to bring in companies to connect with patients and consumers, partner here. So in a year, we'll be thriving. You know, we're excited to bring more companies in, support more entrepreneurs, and also be a place where, based on our location, that we can have conversations with individuals that are driving bills and access to capital for entrepreneurs and early stage companies, so that those individuals really understand what it takes to move science and research and technology forward faster.
So there's probably somebody in the audience, whether here at the convention center or watching from home virtually, who has an idea, who's an entrepreneur who wants to help, especially in the area of maternal and infant health. How do they tell JLabs about their thoughts, their ideas, their innovation, and what's the process for them?
It's a great question. Really simple. It's an online application. You can apply to one of our locations here in the district in Washington, D.C., or any of our other locations around the world. Non-confidential information, and we'll start that conversation of really understanding your science and your technology and how we could fit and help you really move it forward.
So I hope that a year from now, somebody who watched this will actually be at JLabs. That's going to be our goal, is to make sure that we keep finding DC entrepreneurs to go to JLabs. Tell us a little bit about the Quickfire Challenge and the winners of the challenge.
You know, this is a great partnership, and you know, I want to ask you in a minute why this Quickfire Health Innovation Quickfire Challenge. What was important to us is to bring a light to socioeconomic health challenges, problems. We need more solutions. We need more technologies to reach more patients and consumers. We took information from the DC Health Report. We looked at some of the problems that are here, but not only here in the district. It's well known and seen in other areas of this country. We thought maternal mortality is incredibly important, and we heard from the panel prior to us the idea that women are dying in this country and having children is a major problem. We know cardiovascular diseases, we need more solutions, and also kidney diseases. So we worked with your office and the mayor's office and wanted to put out that call for applications on new solutions, new science, risky science. That's what we want to do. We want to incubate entrepreneurs that are going to take risks. And many of these entrepreneurs start from a position of seeing the problem. Either it's a problem they've lived themselves, or seeing a scientific problem and that they have a solution for. So we're excited to talk a little bit or showcase some of these companies.
Yeah, so I think for us, and I see Beverly Perry, the mayor's senior advisor, Polly Donaldson, the director of Department of Housing and Community Development, in the front row. They know the mayor is very keen on getting fresh ideas. She always is asking us, what are the fresh ideas? What ideas are you hearing? And for us, actually, how do you make those ideas into an innovation? That's what's so important. And what we were excited about to partner with JLabs is that it actually puts a little bit of structure around taking something from an idea into actually being a company and then successful thereafter. So Mayor Bowser had challenged us years ago and said that if you could swipe right for love, you could look on your phone, you could order food and have it to your doorstep in 20 minutes. You could do all your banking on your phone. Why can't we help address health outcomes and really tackle disparities with technology and with innovation? And so with that challenge, we have reached out to JLabs. We've got some exciting companies that are going to be locating on the Walter Reed campus. So I think it's time to showcase our winners of the Quickfire Challenge.
Yes, and thank you. We're excited to bring these companies forward in partnership with your office and the mayor's office in selecting these awardees. Each awardee will receive $50,000 and as well as 1-year residency at J-Labs at Washington, D.C. With that, before I turn it over to a video, I'm excited to announce that the companies May, Mama, Vasculonics, Paradox Immunotherapeutics, and Tiny Cargo are the awards this year. Let's go to a short video.
We created Mama from our shared experience of slipping through the gaps of the maternal mental health. It impacts up to 20% of women and even higher for other populations. Women need to feel safe and trusted, and they need to feel like it's a safe place to get help and to share what they're experiencing.
Our healthcare system is deeply inequitable, and in the maternal health space, it is failing Black mothers.
So that's where May comes in. May is really laser focused on bringing these fragmented pieces of care together in collaboration with payer partners and community partners and governments. We have designed our solution specifically for Black expectant and new moms with the goal of driving positive and more equitable pregnancy outcomes.
Diabetic kidney disease is a huge unmet medical need. It's expected to be 650 million people or more having diabetes by year 2040. Vasculonics is pursuing a novel pathway that is very relevant to kidney disease.
Let me tell you a quick story about Anna. Anna and her family suffer from a condition called ALEC2 amyloidosis, a severely underdiagnosed form of kidney disease that may affect 1.6 million Hispanic Americans in their lifetime, which is also one of the highest uninsured patient populations in the US. They've been long considered incurable and without treatment options, but we at Paradox want to change that.
Cardiovascular disease is the #1 rate of mortality in the United States. The current treatments for both of these are either highly invasive, exhibit a lack of efficacy, or most importantly, are out of reach to the very communities which are disproportionately impacted by both cardiovascular and ischemic heart disease. What we aim to do is provide a therapy that is in reach to all of these communities that can be used to reduce comorbidities associated with heart disease.
With our relationships and our experience in the DMV, in particular with marginalized populations, we're really well poised to get started on day one.
The backing of Johnson & Johnson and being given the sandbox of Washington, D.C. With a really critical need to serve families is an amazing opportunity for us and to connect with other innovators and key stakeholders.
Given this existing need, the innovations happening at the community level and at the state and federal level and those incentives coming down the pipe, there's just no better time to forge some of these partnerships than now.
Well, Sally, on behalf of Mayor Bowser, thank you to Johnson & Johnson and to Children's National for partnering with us on this Quickfire Challenge, and we can't wait to be back here next year to hear more about these companies and maybe even our next round of winners.
Thank you so much.
Thank you. Thank you, everyone.
Please welcome to the stage Panel 2, How Reproductive and Birth Justice Can Guide Quality Care. Serving as our moderator for this panel, Jennifer Porter, Director, Mayor's Office on Women's Policy and Initiatives. Let us receive her as she comes. Dr. Jamila Parrott, President and CEO of Physicians for Reproductive Health. Dr. Nolene Jeffers, Co-Chair of the National Association to Advance Black Birth. Ebony Marcel, Director of Midwifery at Community of Hope. Let us put our hands together and receive them at this time.
Thank you so much. Good afternoon, everyone. Okay, we can do much better than that. Good afternoon. Okay, thank you. So we're excited to come together today to talk about a really important topic. In 2018, DC Health released the Perinatal Health Framework. And what it did was outline the 7 priorities to eliminate preventable maternal and infant deaths. And as those priorities have been outlined, our city has been looking and investing in ways to prioritize health and move the needle on health for mothers and for infants in our city. But we know that there's more to do. And so today, I'm excited to be joined by some amazing, phenomenal speakers to talk about the importance of moving from equality to equity to justice. And so let's kick it off, shall we, ladies? Awesome. So let's just start with laying a basic ground for the definition of reproductive justice. And we'll start with you.
Absolutely. Thank you so much for having me. I'm excited to be here. I'm a DC native, and it's always my pleasure to be able to be in a space with the community that made me. I love this question because I think that we hear a lot about reproductive justice in the public space. And as the framework has gained more attention, we hear it mentioned more and more. But we rarely hear her story behind it. Reproductive justice is a framework, a theory, an ideology, a movement that was coined and created by 12 Black women in 1994 who were seeking a broader frame for talking about reproductive health in the United States during that time. And instead of using the language of choice, which really had been the predominant language in the 90s when we were talking about access to reproductive health care, they instead coined this new term, reproductive justice, which brought together human rights, social justice, and reproductive rights. And there are a couple of things that I think are really critical to know about reproductive justice that make it different and unique than reproductive health or reproductive rights. Reproductive justice is deeply grounded in a human rights framework, and that was intentional because human rights are known to be universal, indivisible, and interdependent. So that means everybody, everywhere, is entitled to these rights, no matter whether their gender, their income, their race. And it's also resting on centuries of Black feminist thought. So thinking back to Sojourner Truth, Mary Church Terrell, these Black women who were talking specifically about the unique experience of gender oppression and racialized oppression in this country, and the way that created a specific and unique circumstance for Black women. One last thing I'll say about it, it's important to also understand that this was a framework, as I said, created by 12 Black women, but it really was meant to encompass the experiences of all people, recognizing that all of us live at the intersection of a number of oppressions, and it is the condition, the context of our lives that creates the experiences that we have and impacts our ability to exercise our reproductive rights.
Thank you, and thank you for that. Just breaking that down, when we hear the concept of reproductive justice, there are very different things that come to mind for different people. And we know when we talk about birth justice, we're talking about something
different. So can we talk about the genesis of birth justice?
Yeah, so there are 4 core tenets for reproductive justice in the reproductive justice framework: that every person has the human right to have a child and to determine the circumstances and conditions under which they give birth; that every person has the human right to not have a child and to have the information and resources necessary to prevent or end a pregnancy; every person has the human right to parent the children we already have in environments and communities that are safe and sustainable and free from violence from the individual or the government; and every person has the human right to exercise bodily autonomy. When we talk about birth justice shows up in that first tenet of reproductive justice, that human right to have a child and to determine the circumstances and conditions under which we give birth. When we look at the inequitable outcomes for Black women and Indigenous women and birthing people in particular, we see that this human right is in jeopardy. Many of us are dying in childbirth in the postpartum period, and birth justice really rests on saying that whatever systems and circumstances you need to thrive, certainly to live through and beyond your pregnancy, is a human right to which everyone is entitled. And I do want to invite the other panelists to, if I missed a piece or to join in, please do.
Thank you, and I think that was helpful to really frame what we're talking about today. A lot of times when we're having a conversation around maternal health, conversations in public health, we talk about the concept of respectful care. Ebony, can you talk to us a little bit about what does that mean and how is it connected to what we're talking about here today?
Sure. I really don't like that term. I'll just say that. It's a term that really continues to sugarcoat and not really address what we need to talk about. It was commonly used to describe changes that they wanted to make in maternity care overseas, but to me, that's really based on conversations about physical abuse versus here we need to talk about racism and bias and how folks are engaging in care. So I'm not a huge fan of respectful care, and I think that I'm going to continue to push the envelope to say we need to have a bigger conversation, not just say we're talking about respectful care. And I also wanted to add to Jamila's conversation, it's also about centralizing the most marginalized. And that's a huge piece of what reproductive justice is.
Thank you. Dr. Jeffers, when we talk about this concept of reproductive justice, we know that, to Ebony's point, the impact for different parts of our community are disproportionate. Can you talk a little bit about the impact of reproductive justice in our community? And I think as we discuss impact, we can also talk about the impact of the language that we use around this concept.
Absolutely. So reproductive justice, I think the strength in this framework and theory is that, as Ebony mentioned, it is centered on the needs, barriers, strengths, challenges of people that are most marginalized. So we think of that as people that are disabled, immigrants, Black people, people of color, people that are trans and non-binary. And I feel like there's a real strength in that, right? When we center the most marginalized, then we understand what are the gaps, how can we transform our care to make sure that we are promoting equitable outcomes, and through that, we can produce more just systems of care as well. Now, in terms of language, I think one thing that's really important, I don't know if you've noticed, but we're using sort of gender-inclusive language here. So we typically will say Black women and birthing people, and that's really important as well. Understanding that people come from various identities, and it's important to honor that as well in our work.
And if I could add a little bit to that, I love that, right? This understanding of centering those who are most marginalized, right? Because this, when we think back to the reproductive justice framework and its origin story, it wasn't a framework that was created by doctors or nurses or public health agents necessarily, right? But community organizers. And so what they were doing is really trying to coalesce into this grassroots approach to shifting systems and structures so that we all have an opportunity to thrive. And as an organizing principle, what we're talking about is centering centering the margins. And so if you build systems and structures that actually benefit those who are most marginalized from care, then everybody else on the center will naturally benefit. Our healthcare systems as they currently exist are designed to center those who already have a number of privileges. If you're insured, if you have a doctor, if you don't have any income inequities, right? If you're not struggling to actually receive your care, you will get care. But those who are on the outsides continue to struggle. And so this mobilizing and community organizing framework really prioritizes that. And this piece about language, I think, is really a challenge, I think, for lots of us, because language changes constantly. And so the language that we use today may be different than the language that we use tomorrow, next week, next month, next year. And we have to make room for that. The different ways that we think about the work, the way that we talk about the work, and the way that we hold the work. Certainly around gender identity and sexual orientation, about race, around economics, around the way that we even phrase how we're talking about community, right? So the use of people-first language, not low-income people who are living on low incomes. Not marginalized communities, but communities who are marginalized. Because what it does is it helps remind us that we're talking about human beings. These are people first, and the other additional pieces of the work are often a result of oppressions that we have designed and allowed to flourish in our systems. And so it's a reminder for us to really shift our thinking as we're talking about the work, because it will force us to approach it in a different way.
Good. So, okay, we have a good working definition and understanding of it, but let's just kind of break this down. What does it mean in practice? What does reproductive justice mean in practice? And Ebony, I'll go to you because I think it's important to not only understand it, but to see it and to be able to really understand what it looks like in practice.
So there's different layers to this, and definitely I want to refer to my co-chair from NAB to discuss our Black Birthing Bill of Rights, to talk about what's important for the individual. I want to talk more so about systems. I feel like as we've been continuing to kind of tippy-toe into this difficult conversation, we keep putting a lot of energy towards the individual. And we're not going to fix anything by a couple of folks going to a bias class for 4 hours and now everything is fixed. We need to talk about our systems. And what that means is acknowledging that they're broken, acknowledging that they need to be rebuilt, acknowledging that what we have done in the past is not working, and really, really moving towards changing how we've been providing care that includes a non-biased environment, an equitable environment, an inclusive environment.
And so Ebony actually mentioned the Black Birthing Bill of Rights, and I encourage all of you to go to the website of the National Association to Advance Black Birth. In April of 2020, we disseminated a list of 20 rights that we believe that each Black birthing person is entitled to. So these rights were created and informed by evidence and also the lived experience of Black birthing people. And they cover the gamut of what is an optimal experience from pregnancy through postpartum and early parenting, including the ability to choose your care provider, the ability to have support that you choose during birth, the ability to have affordable care, to have anti-racist care, to be respected, seen as a full human being, and to have your identity respected, and to be able to make decisions for yourself and your baby. So I encourage you to take a look at the Black Birthing Bill of Rights. They're not just a list of rights for Black birthing people. Of course, it helps the person to understand what is really this optimal care that is going to help me to thrive during my childbearing year, but it's also for healthcare providers. What's the level of care that I should be giving in order to provide equitable care? And it's for healthcare institutions. Hey, how can we transform our policies, our systems, our structures so that we're more in line with making sure that we're optimizing the rights of Black birthing people?
Sure, I'll add a few words. I think that, if we take a zoom out and thinking about a broader approach to how we are hoping to address inequities in our systems. Ebony talked about the systems level issues, right? Not thinking about trying to find the individual fix. And also, Dr. Jeffers mentions this Black Birthing Bill of Rights. How do I, as an individual, advocate for myself in these systems? And so we see these improvements, these suggestions are opportunities, levers for change that are showing up in a number of spaces. It also shows up in the policy space. A lot of the work that my organization does, Physicians for Reproductive Health, really leverages the medicine and the science, the evidence that you've heard them talk about, to shift policy change. And so we've seen that really take hold, even at a federal level, with the Momnibus Act of 2021. And Representative Alma Adams and Lauren Underwood and the Black Maternal Health Caucus are pushing this legislative package of 12 bills that says just that. What does it look like if we center the margins, if we create policies and legislation that actually advocates for those who are least likely to get care? What kind of changes in our systems could we affect? And the other thing that I'd say about how it looks in clinical care, as an OBGYN and a family planning specialist, and I know as midwives, we all have trained a number of other providers. Medical students, residents, fellows, nursing students, midwives, and we really have an opportunity in our training programs to flip the table over, to talk about exactly what Ebony mentioned. We're not talking about respectful care. We're talking about undoing the white supremacist and racist legacy on which our medical institutions were built. That is the beginning point. We have to really grapple with this dark and complicated history of racism in our medical care, and particularly in the reproductive health space. We don't have far to look, right? Thinking back to the names that we know, Marion Sims, right? Thinking back to the providers who bought and purchased enslaved people for the express purpose of experimentation. This is a legacy that we have to grapple with as healthcare providers. And we also must continue to teach it to the people that we've trained so that we do not repeat these atrocities as we continue to move forward.
Thank you for that. I know that when you mentioned trainees, and while we know that in training there's so many priorities and so many concerns with our community health that can be prioritized. But as we move towards a place of reproductive justice and birth justice, what are some of those additional things that individuals who are training the next generation of providers should be prioritizing?
So I mentioned that I'm from here. My grandmother has this phrase that she talks about, the come heres and the from heres, right? And often the come heres believe that they have all the solutions that the from heres, who have been here for many generations, are living through. And I mentioned that in the context of medical education because our medical education systems aren't designed to demand that you learn about the community you're charged with caring for. Right? And I think that ahistorical perspective impacts our ability to care for people. I intentionally trained in DC, went to medical school at Howard, continue to practice in this city because I believe in the people here and I care about the health of individuals here. But you don't have to be from here to be able to take good care of the folks that made me. But you do have an obligation to learn about the history of this city, about the people, the relationship of the individuals in this city to the institutions where they seek care, and how that impacts our ability to move the needle on these inequities. And I think that that's a really important place to start. What is our responsibility as healthcare providers, and what do we need to know to take good care of the folks that we serve?
And I think in education for healthcare providers, whether it's in medicine or in midwifery, it's important that we move away from sort of individual blame narratives as well. I feel like there is a lot of attention still on concepts like cultural competency, which focus on understanding sort of how to give care to specific communities, when in reality we should be teaching our students about structural competency. What are the structures in place that continue to produce inequities and injustices in our healthcare system and our reproductive healthcare system in particular? And so really our job as educators is to make sure that we're constantly helping our students to think about the structures, the systems in place, rather than thinking about individual people and putting blame on those individuals and communities.
And I just want to add what Dr. Jeffers kind of said. Sorry, that got loud. I apologize. Whoa. With just a quick understanding of what she just broke down is medical students not saying this is a Black woman and already deciding that she is full of risk and trouble and problems and attitude and possibly thicker skin, to understanding that she's a whole human that needs to be cared for, and that depending on where she is coming from, there could have been a lot of redlining, barriers, generational chronic stress that contributed to possibly why she's in the position that she's in.
And not only that, each individual, each community has strengths, opportunities. How can we capitalize on that and help them to use those strengths and those opportunities to improve care and to improve outcomes as well?
So important. And continuing this conversation with this framework, another concept that we often talk about trying to prioritize in public health and in maternal health is access. And we know that when we talk about access, a lot of times people go to this very physical concept of being able to touch a particular service or provider. Can you talk a little bit about what access means with the birth justice framework?
For me, access is bigger than just having a space for people to get care, because definitely at moments in time, there was question of whether or not there was access to care in DC. There's always been access, but people weren't engaging in that care. That's the question. Why aren't people going to where the care is available? To me, access means individuals receiving care from folks that look like them. So that I'm talking about cultural congruence and how that is automatically a way to de-stress individuals, not having to code switch, not having to feel the pressure of worried about bias that they may be engaging with. To me, access means providing care without systems that are punitive, making sure that late policies are pretty much broken. We gotta meet people where they're at. To weekend hours, to night hours, to identifying what people are asking you for and trying to give it to them, not building systems on what's easiest for us. So to me, I can keep going, but access means a bunch of things to me.
And I just want to really echo what Ebony's saying, that it's more than brick and mortar. You can put 1,000 clinics east of the river, and if folks aren't getting the care that they deserve when they show up, you have done nothing. You have wasted your time. And so we really need to broaden what we're thinking about, what we're talking about, and what we're hoping to achieve, and ground that deeply in our values. I think this question around cultural congruence is a really important one and an under-focused issue, right? What does it mean to show up to a provider who looks like you? To care for communities and to show up and for a Black woman to be cared for by a Black doctor is a big deal. And so we need to understand that to show up and have someone who speaks your language, who comes from where you come from, is a big deal. And so we need to really invest in our training program so that we can ensure that folks are able to be received in community health spaces by folks that really do understand their lived experience and value them. And I think the last piece that I'd say about access is really around what our responsibility is as providers and how we need to shift the power dynamic that is inherently built into our systems so that they go back to the person to whom they belong, which is the individual that's seeking care. Our systems are designed to disempower folks that are seeking care. And as both a doctor and a patient, I see this play out in all kinds of ways. And me being a healthcare provider, knowing that I hold a lot of power and privilege that many folks don't, and still feeling consistently disempowered in healthcare systems. When you are disempowered, then survival is key. And your ability to focus on all of these other intricacies really decreases. And so how does power play out in our systems? And what is our responsibility as healthcare providers, as folks with power, to ensure that that power remains with the individual?
Thank you. So you mentioned some of the legislative work that is going on in this space. And I'm wondering if you could share some of the other things that are emerging in this space, whether it's in the advocacy space or in education, that our audience that is watching and that's here today can look to learn more and see what's emerging. And that's for anyone.
I'm happy to start. So the organization that I run is a physician advocacy organization, but there are lots of other advocacy organizations that really understand what we call the power of the white coat privilege, right? There are spaces that as a physician I'd be allowed to enter that many in the community that I serve and I come from would never have an opportunity to enter. And the question becomes, what is my obligation when I show up there? And for me, that obligation is to always bring community with me and to prop that door open with my foot and make sure that I'm bringing as many folks into the table as possible. And so the advocacy work that we see from medical students, from nursing students, from midwifery providers, from physician providers, to really ensure that the voices of the communities we care for are showing up in these conversations around policy and legislation, and whenever possible, to the degree possible, making sure that the patients aren't talking through me, that they actually are the ones who have the right to be sitting there and telling their own story. And that's a huge part of the advocacy work that we see. We need to make sure that those that are making laws and policies know that there are real people at the end of this legislation that will be directly impacted by this decision making. And so that's the work that we do at our organization and the work that I know a lot of us do around advocacy.
Emerging trends.
Yeah, I mean, I mentioned previously the Black Birthing Bill of Rights, so I'm just going to talk a little bit more about that. I think it's important that we think about how we can sort of reimagine care, and utilizing the Black Birthing Bill of Rights provides a framework for thinking that through and providing changes at the structural level as well. So with the Black Birthing Bill of Rights, we talk about racism and the impact that that has on care. We talk about obstetric violence, how that intersects with racism, and how people are due for having mediation, for really confronting the harm that they experience on a daily basis and on a health basis as well in terms of their encounters with healthcare providers. So I just want to draw more attention to that and definitely encourage people to think about, hey, how can I incorporate this into my care as a healthcare provider? Can I print this out, provide it to my clients, let them know this is the standard that you can hold me and our institution to as well? Can I print posters, put them up in our clinic so that clients can say, hey, this is what I should expect, and know that this is the baseline of care, which is actually a wonderful ceiling as well.
And I would be remiss if I didn't talk about the birth center. A lot of people don't acknowledge the fact that we are the Community of Hope has the only freestanding birth center in Washington, D.C. I cringed a couple weeks ago. I was somewhere and they were like, there's no birth centers in D.C. I'm like, yes, there is. The other piece that makes us special is that we are a federally qualified health center that has a birth center. We are one of 5 left in the country. I said 5. We have a very unique model. We provide incredible care, but talking about access, talking about reproductive justice, out-of-hospital birth is often not an option for marginalized populations because of cost. We are a birth center that accepts Medicaid. We are not being utilized to the capacity that we should be being utilized. And we are actually moving, only down the street, y'all, don't worry. We're not going far. But in our brand new birth center, I'm hoping that I'll engage more of the community to utilize out-of-hospital birth. It's transformative, it's important, and again, it should be an option, especially for marginalized families.
And I guess I would love for each of you all to share with our audience and just with the birthing people in Washington, what does the future of reproductive justice look like if we were to dream forward and speak specifically as we do the work to change the ecosystem? What does the future of reproductive justice look like?
So I think from my perspective, the future of reproductive justice is intersectional, right? So when we're thinking specifically about Black communities, there's no monolith, right? We're not all the same. We're heterogeneous. And so what does that mean? It means that reproductive justice holds space for individuals that are disabled. It holds space for people experiencing violence. It holds space for people that are experiencing the impact of climate change, right? It holds space for people that are experiencing impacts related to environmental pollution. So I would love to see reproductive justice as it pertains to Washington, D.C. and nationwide, to really think about how reproductive health is impacted by all of the other issues and injustices that are experienced today.
Ms. Marcel.
I don't want it to be a hashtag. I don't want people to just commonly use it. And I also want people to be clear that it was a framework that was created by Black women, and not to be disrespectful, but just to say that not everybody can implement reproductive justice, being really honest. I want there, now that we've had all this awareness and gloom and doom, I'm looking for some more joy, some more Black joy, celebration, thriving, to be discussed when we talk about reproductive justice. We've spent a lot of time focused on a lot of the negative, so my future of reproductive justice is about Black joy.
Beautiful.
That's hard to follow. I think, you know, we all want joy and deserve it, right? And so to me, the tie in for all of these things in the future of reproductive health, reproductive rights, and certainly reproductive justice is liberatory, right? And so for me, in seeking liberation, my liberation will look different than Dr. Jeffers' liberation, will look different than Ebony's liberation. And so for me, the future means that each person has an opportunity and a right to decide what this liberatory future looks like for them, and to have the systems and resources necessary to support and truly sustain it. So freedom for me, liberation for me, may look different than it does for anybody else in this room, and still I get to decide what that looks like, and that to me is the future.
Thank you, ladies, for sharing. Dr. Jeffers, Dr. Parrott, and Ms. Ebony Marcel, thank you so much for breaking this down. A hand for all of them. We want to continue this conversation beyond today and beyond this stage around how reproductive and birth justice can help us to move the needle in maternal health, and also bring us to a centered place of inviting more joy in our birthing experience, particularly here in DC. So as we do this, we want to encourage you all to continue to join us as a part of this conversation. You can join us over at Mayor.dc.gov and utilize the hashtag DC Maternal Health to continue the conversation. Let us know what you're thinking. We want to hear about emerging trends and the work that you're doing, because we do this together. That's a part of the future of reproductive justice as well, sharing our stories. So want to thank our amazing panelists for today, and continue the work.
Yes, ma'am.
Thank
All
you.
right. Thanks, ladies.
Ladies and gentlemen, please welcome back at this time Dr. Faith Gibson Hubbard, Director of the Mayor's Office of Community Affairs and Executive Director of Thrive by 5 DC.
Hey, good afternoon again, everyone. And wasn't that panel just fire? Weren't they amazing? And I just have to say, you know, I feel so inspired every time I get the opportunity to see those great women take the stage. So I just want to say cheers to them, and also for their great work in helping us to continue to feel acknowledged and seen. And today has been such a great lineup of panels. And while we are getting ready to wrap up the main stage, the party does not end. It doesn't end in this convention center. It doesn't end if you are on dcmaternalhealth.com watching. But we have even more to come. And so I hope that you have enjoyed yourselves and that you will continue on this journey with us. So what we've seen already in our sessions today is, again, that maternal and infant health is a huge indicator of the health of our entire community, right? It's not just about the moms, it's not just about the babies, it's about all of us and the choices that we make together in order to support their needs and our community's needs. So what you've seen and what you've heard is us moving from discussion to action, and we want you to be even more of a part of that. And so I will talk to you in just a second about some of our affinity sessions that are happening downstairs, and food. There's going to be food downstairs. I know people have asked me about that. So there will be food. But I first want to go back to thank our sponsors: Sibley Memorial Hospital, Care First, Johnson & Johnson, United Healthcare, March of Dimes, MedStar Health, White Ribbon Alliance, the George Washington University Hospital, Children's National, and Aetna. Their partnership has made today possible, but so has the partnership of so many of our district government agencies, such as the Mayor's Office of Community Affairs, the Mayor's Office on Women Policy Initiatives, and you just saw their amazing director here on the stage, DC Health, Serve DC, the Department of DC Healthcare Finance, the Department of Employment Services, and Thrive by Five, of course, and all the work that has been done to make today possible. But before I close, I want to share with you just a really exciting opportunity and partnership for all of us. So in the Bowser administration, we are always trying to find different ways to make sure that residents can be connected to all the resources that they need. And we are partnering with Canopy, an app that is provided free, evidence-based mental health care to every expecting and new mother in Washington, D.C., because we know that perinatal mood disorders, and you heard Ms. Spicer talk about this earlier, is something that we have to be focused on. And we know that it's a #1 complication from pregnancy and childbirth. And as someone who has experienced postpartum depression myself, I also know that it is something that we're so afraid to talk about, because I'm just talking to you about it right now, right here. And we don't need conferences like this to tell us that we need to, but we need to normalize this together, and Canopy can help us do that. So we invite you to try it out, and we will share more about that partnership with you through the way that you have registered today. I also want to tell you about our Maternal Mondays Live, which normally we have this on Facebook Live, but we will be doing an in-person event in partnership with March of Dimes, and also their Mama and Baby Mobile Health Center at Sandlot Southeast next Monday evening. And so we will be sharing that information with you. It's a great time to be outside, for us to enjoy each other's company and time, and once again, to center the narratives and needs of moms and babies. I just want to thank our amazing mayor for everything that she continues to do, not only just in the space of maternal and infant health, but in so many other areas. And you heard her earlier talk about how we have to think about health in all policies and in all actions. And so she lives that, and she requires all of us to live that, and we then extend that to you through opportunities like today. So just thank you to Mayor Bowser for this opportunity for us all. Yes. And so now, I want to tell you about what else you can be doing with us today before you go. So again, I told you on the second floor, there'll be food, so that should be one draw. But the second draw should really be the affinity groups. We know that every time we meet for the Maternal and Infant Health Summit, we have great panels here on the stage. But we know that each one of you have stories that you have to share. Things that you want to get off your chest, other people that you want to be in community with, and we don't always get the chance to do that because other people are sharing their stories and what their work is on the stage. But we all have different things we want to share, and the affinity groups that we will have downstairs on the second floor will allow us to do that in several different spaces. For those who have experienced perinatal loss, for LGBTQ+ individuals and families who are looking to extend their families or start a family, sessions for teens and young parents, for families with disabilities, fathers, and for grandparents and older caregivers. Again, these affinity groups are reflective of our village, and all of us who have to show up in order to ensure that we can have better maternal and infant health care, and also that we show that real value within our community and that people can be reflected. So I hope that as we gather together down on the second floor with the food in the sessions that we can really continue to connect with each other and have more conversations. So I hope that you have already signed up for a session, but if you have not, you can just venture down to the second floor and you can find a room that might work for you. Those discussions will be led by community-based organizations and also some of our agency partners for us to have our own personal experiences together. And so I look forward to joining you downstairs on the second floor. But before we close, I just want to thank you for always making this conversation possible, whether it is through streaming or whether it's here in the convention center. It is so great to be convened and also for so many people to be seen around maternal and infant health in a way that we don't always discuss. So thank you, and let's applaud yourselves. And I look forward to you joining us downstairs. And I also want to just remind, too, that tomorrow is day 2. And day 2 and the agenda can be found on dcmaternalhealth.com. It is fully streaming tomorrow, and you will have the opportunity to take part in so many amazing breakout sessions that will happen tomorrow that are led by community-based organizations. So we won't be back here. You can do this in your own home or at your office or wherever you want to, in your car. You can log in to dcmaternalhealth.com and join those conversations. So with that, I conclude this part of the Maternal and Infant Health Summit, but hope to see each of you downstairs and also tomorrow online at dcmaternalhealth.com for our breakout sessions. So thank you.